zero metal PCI in a case of in-stent restenosis. Patient had a history of inferior wall MI in 2019 with PCI to right coronary artery and left anterior descending coronary artery. She had again NSTEMI on 20th September 2023. The angiography at that time revealed left main coronary artery disease, 50% occlusion, LAD stent ISR 80%, and there was osteoproximal RCA 90% disease. This was a new disease, and mid-stent ISR and diffuse PLV disease. She had left main LAD bifurcation PCI at that time with 2 deaths in LAD and 1 in LCX, and PCI to RCA with 1 death. Now she presented to our emergency within 3 months of this last NSTEMI with NSTEMI again with no localizing changes in ECG. So we took the patient for coronary angiogram. There was a LCX ostial stent ISR of 90%, and there was LAD stent mild ISR with underexpanded stent. There was diagonal 100%, probably it was a prior disease. So visibly the LCX stent ISR was 90% and LAD didn't show any significant ISR, and RCA mid stent ISR was seen 30 to 50%, and distal there was 50 to 70% disease. So we counseled the patient for CABG in view of repeat ISR, but patient denied, and then we took the patient and for the coronary angioplasty, we took the femoral axis, we wired both the vessels with Fielder FC wire. We first pre-dilated the circumflex because it was a tight lesion, so we couldn't, we decided to do the imaging, so we couldn't pass the OCT through this tight lesion. We pre-dilated circumflex with 2.5 12 mm balloon first, and then took a OCT run. So this is a pre-PCI OCT run in circumflex. We can see that there is a significant neointimal hyperplasia at circumflex ostium. We can see in the picture, and there is a MLA of 1.91 mm square. This is the OCT run in LAD. Here we can see that there is a diffuse neointimal hyperplasia, and 2 layers of stent can be seen in LAD. And the luminal area is 1.65 mm. So minimum luminal area is 2.23 millimeters square. So although visibly LAD didn't show any significant ISR, but on OCT there was significant ISR in LAD also, and there is 2 layers of stents. So after this OCT run, we again counsel the patient for CABG, because there are LCX severe neointimal hyperplasia with underexpanded stent, LAD no 2 layers of stent, but patient decided to go for angioplasty. So we thought we will do the angioplasty LAD LCX bifurcation with using DEB, as there is again chances of in-stent restenosis in this case. So we pre-dilated the LCX with 3O cutting balloon, and also, and then after that with 3 into 12 mm NC balloon, we put we dilated the LAD stent with 2.5 12 mm NC balloon at 18 atmospheric pressure. It is not running. This is the ISR management algorithm. So first we put a 2.5 20 mm balloon. After the optimization of the previous stent with NC balloon, we put a 2.5 20 mm drug-eluting balloon in distal LAD. Then we did a kissing balloon dilatation with a 3 into 15 mm balloon in LCX and 3 into 12 mm balloon in LAD. We did a modified pot in LAD at 16 ATM, 3.58 mm balloon. Then we put a 3 into 14 mm DEB balloon and deployed at 16 ATM in LED, and 3 into 17 mm drug-eluting balloon deployed in LCX subsequently. Then we did a final kissing balloon dilatation at 12 ATM with the same balloon, and this is the post-PCI run in the LCX and LED. This is LCX and LED. So the post PCI MLA in LED was proximal was 9.1 and distal 5.93, and LCX 4.5 with no major dissection and with fair luminal gain. And this is the final result. So the take-home messages are: imaging should always be used in case of complex PCI for optimal PCI results and prevention of repeat procedure. CABG should always be the first options in such patient and should always be emphasized. Drug-eluting balloon are useful in patient of ISR to prevent excess metal. Optimal result can be obtained using drug-eluting balloon in such cases, and their use is increasing in coronary intervention. Thank you.
Yeah, thank you. I had a few queries. Is CABG an option in this patient? It's a non-LED lesion. It's only LCX stent which is, restenosed.
Angiography, it was looking as if LCX is the only culprit lesion, and there is no ISR in LED. But on OCT, then there was.
I don't think no surgeon will accept this case for CABG. It is a non-LED lesion to stent only OM. I don't think surgeons will accept it, and I think that should not be.
ISR, that is why.
Single time, and that's a known thing actually.
The second ISR now.
But even then, I think it's just for a OM bypass difficult. You will have to do with them. Whatever you have done is the right thing. The other thing I wanted to know, in LED, angiographically there was no stenosis as such, but you have used DEB.
Yes, because on OCT, the luminal area was less and there was diffuse neointimal hyperplasia and that also.
What was the angiographic stenosis? What you calculated in OCT, what was the MLA?
It was 2.2, ma'am.
2.2. So whole of LED stent you have dilated with DEB.
Whole LED stent dilated, and then in mid LED we put 20 mm depth, and then in ostial and proximal LED 16, and in LCX 17 mm.
And what cutting balloon did you use for to deal with this neointimal hyperplasia? What is the cutting balloon? Which one did you use?
Wolverine.
Wolverine.
Nice case, Dr. Monica. It was an excellent case. But just remember the recent 2023, what they've insisted is the L6 ostium, however meticulously we stent with the IVES or OCT guidance, it tends to get occluded again within 6 months. That is to say, within up to 50%. So L6 ostium stenting, it's a big challenge. We have to deal with it. And your putting of a DEB in the presence of an L6 ostium, it's a good choice. But what are the studies to contemplate that? Studies. What are the studies involved in putting a drug-eluting balloon in the L6 ostium? Yeah, just go through that. Very good. And what atmospheres did you dilate the drug-eluting balloon? What atmospheres you have put here at 16, 12? Normally, how much do you go for a drug-eluting balloon for the medicines to be fully deployed there? What atmospheres you would go?
Ma'am, it may be 16 or 20 atmospheric pressure.
No, even more than that. For how many seconds you go?
How many?
Seconds.
Seconds, ma'am. Approximately 30 seconds.
30 seconds. And what are these studies to show we can even go up to 60 seconds in certain conditions? Yeah, kindly get updated with that. Thank you so much. It was a lovely presentation, otherwise. Thank you.